Hello, everybody. My name is Ed Pierce. Some of you may know me as the editor of the Citizen newspaper here in Laconia, but some of you may not know that I'm also the vice president of Stand Up Laconia. What is Stand Up Laconia? In a nutshell, Stand Up Laconia is a grassroots coalition that aims to eradicate the scourge of drug abuse from our community. How does Stand Up Laconia go about that, doing this monumental task? We are working at in 4 different realms. We're working in the realm of prevention, intervention, treatment, and recovery. And to that end, we are going to have a discussion today with 2 community leaders here in Laconia. I'd like to introduce one of our guests today is Jackie Abakoff, and she's from Horizons Counseling Center. And our second guest is Dr. Paul Rassicot, and he is a physician at Lakes Region General Hospital. Welcome to both of you.
Thank you.
Thanks for being here.
Thanks for having us.
This is an informal discussion, so I'm going to throw out some questions, and feel free to jump in. And my first question will be for Dr. Rassicot. Can you tell me, from your perspective in seeing treating people at the hospital, residents of the community, can you tell me what are some of the physical dangers associated with the abuse of prescription drugs?
Well, Ed, I've been an ER physician for 30 years, but I've also been part of Jackie's program at Horizons, the Nathan Brody Chemical Dependency Program, which I act as medical director of. So I've had experience on both ends. And, you know, the problem with prescription drugs are that they hit pleasure centers at such a rate that people quickly get addicted to them. And the other problem is the amount of drug you then need to keep up that habit. It goes up quicker than alcohol or any other drug that I know of. Oftentimes, you need to double your dose every month to get the same effect. So you can see how quickly someone gets into trouble on the money end. And a lot of reason why after a few years people switch to heroin is it for a while is a little cheaper alternative, but that again continues to grow. And most of our active addicts that we have, Jackie and I, either in Suboxone or in our program, probably need $1,000 every 4 to 5 days. And you know where that's going to come from. It's going to come from dealing or stealing or both. You know, and that's in the physical part is really all of the medical problems that come with narcotics. You know, we have some pictures of brain scans after 5 to 7 years of use of narcotics, and the brain looks like it's been mothball eaten. These receptors that are constantly being hit in the brain, the pleasure centers, they start to not work as well. They start to scar down, and a lot of that means with legitimate injuries, these folks need much, much higher doses to get any kind of pain relief. Not to mention that introducing a needle into your arm several times a day, it gives you a big risk of introducing bacteria into your central bloodstream, and oftentimes it comes with horrendous medical problems, including big bacterial vegetations on heart valves, which then throw off to cause strokes and to lose limbs.
So the infections too?
Yeah. I mean, they usually end up introducing a staph infection into their bloodstream because they're constantly using that access, and perhaps not with the same antiseptic technique that we would be using at the hospital. And you know, the amount of days these folks have to spend in the hospital and how sick they are at 25 years old is amazing. So, Yeah, yeah, the health. I tell my medical students this population, being young 20s, say, is the most unhealthy population they'll ever come across. Anything and everything can be wrong, and they're usually horrendous things.
Thank you. Jackie, as somebody who's been on the forefront of this issue for some time now in the city, what do you think is the role of recovery support in the continuum of care here?
Okay, well, I think the really important thing is the continuum of care to begin with. And that's something that our state in particular really needs to develop. What we have to do, and I was really glad to hear you mention that Stand Up Laconia is working in the areas of prevention, intervention, treatment, and recovery. And we've been working in the areas of prevention and treatment for a very long time. We're just beginning to understand the role of intervention and early identification. The role of recovery in the continuum of care is really not a new concept. It's actually a very old concept, but it's one that we have just begun as a profession to embrace. We've known that peers helping peers has been a huge road to recovery for millions of people for an extremely long period of time. I mean, since since the 40s, when we saw the beginnings of 12-step communities. Today, what we're understanding is that that when people go through treatment, they get the professional help that they need in order to learn the skills to stop their addiction and to maintain recovery. What they don't get is an understanding that this is a chronic disease that needs ongoing care for the rest of their lives. That doesn't mean they have to be in an expensive treatment center or even involved in counseling for the rest of their lives, but they have to have some foundation and have the support of people who understand where they're coming from. And so what we're beginning to look at in this state is the development of peer-to-peer counseling programs and recovery support centers where folks can go after treatment so that they continue to get the support that they need, where they can go during treatment so that they can learn the skills from folks who've been there, so that there's an understanding that there's more beyond 12-step communities, that there are many pathways to recovery. And because of the unfortunate situation in our state where we have so few resources for recovery itself, for treatment itself, that this is a place where people can go for the initial help and support to get them through, to keep them motivated to get into the treatment programs while they're waiting on very unfortunate wait lists.
Thank you. Doctor, there seems to be, in New Hampshire in particular, a debate, especially for funding purposes, for programs to combat or thwart drug addictions here in the state. There's a debate going on about, is drug addiction a disease? And what's your thoughts on this? Is drug addiction a disease?
Yes, Ed, it's a disease because of many factors related to drug addiction that meet the disease definition. To start with, it has a very high genetic predisposition. In fact, if mom and dad are both addicts, the children are all at tremendous risk. And oftentimes we see in those families that people either use no substances at all or they're addicts. So it certainly meets the criteria of inheritance. And, the inheritance does put some people at risk, but also it meets disease status in terms of the circuitry in the brain that seems to be almost, I always say to my addicts, it's hijacked your brain. And when we got to the point where we could do sophisticated scans, we also realized there are certain parts of the brain that light up in addicts that don't in others. So there's certainly some differences in the brain now that we can see that are objective findings. And I think that, you know, most of the medical community, certainly in the U.S., would recognize it as a disease. And it's a disease not unlike hypertension or diabetes that you get up and take care of every day. You'll have some relapses, and it's a lifelong disease. And any of our friends or family members have had battled addiction. We know sometimes after 20 years, when none of us can figure out why, but they start using again. And so that's why it certainly, it's hard for medical practitioners, because most of us were trained, especially in the emergency room, that people came in and you got them better, and it was a very short time frame for the most part, and you congratulated yourself and they did, and you. But this is a disease that some practitioners, it has to be the right practitioner involved who sort of says, this is a chronic disease, and you know, we're going to battle it and battle it and battle it. And Jackie has people that have been in program 2 and 3 and 4 times before they, you know, I always say we're sowing the seeds during those times.
Sure.
And you hope you get some fertile ground, and you hope you get a, you know, even a 2 or 3 year sober period allows the body to heal up quite a bit. And also during that period, people sort of recover somewhat physically, but also mentally, with counseling and with a program. So it's a different disease certainly than what most emergency room physicians, and you know, I try to tell other physicians it's part of the human condition. In the United States, about 33% of people are addicted to something.
Not that many.
It's a third. And when you look at the addiction numbers, it's pretty steady that 10% will become addicted that use narcotics, 10% become addicted that use alcohol. Right down the line, marijuana, 10% become addicted. And the irony is the most addictive substance out there is nicotine, which 33% or a third become addicted that, you know, start to use it. Right. So the addiction rate is much, much higher in these than we ever thought. You know, early in the 80s when a lot of these long-acting narcotics came out, like OxyContin and things like that, you know, a lot of the literature was saying the addiction rate was less than 1%. Well, we know it's 10%. And in Vietnam, the GIs that came back with a heroin addiction, about 10% continued to have a problem with heroin. When, you know, so it's been shown over and over. That's about what the number is.
Okay, fair enough. Jackie, you know, we have, obviously, there's a problem here. So can you make the argument why treatment services should be expanded in the community?
That one should be self-explanatory. I mean, if you hear what Dr. Asicott said about 10% of the population having an addiction to a substance other than nicotine, which is way higher, then there has to be an understanding. I'm not sure off the top of my head what the population of New Hampshire is, but that's a lot of people. And what we know is that about 75% of the people who need treatment in our state are unable to access that treatment in a timely manner. Right now, we're very focused on the heroin epidemic. And in some ways, I'm glad that it's gotten us the kind of attention that we need to have. But in other ways, I get concerned that there's going to be this lack of understanding that addiction goes way beyond the heroin epidemic. More people die of alcohol dependence than they do of heroin. Of course, it's not as dramatic. It doesn't happen to lots and lots of young people instantly. It's a long, slow death, but it still kills a lot of people. It also kills a lot of people on the roads. So it happens from both ends. What we have to do is find a way to get these people the treatment that they need in a timely manner. When someone has a disease and it comes to the acute point where they're either in a hospital with an abscess, or they're in the hospital being detoxed, or they're simply sick and tired and decide this is the time because of all the consequences in their lives, they need to be able to come to a treatment center and not be told, we're really sorry, it's going to be 6 weeks or 2 months or 3 months. Whether we're talking outpatient treatment, intensive outpatient treatment, partial hospital, or residential treatment, it needs to be available on demand, because what we know about folks who are in pain is that they're going to do something to try to stop the pain. They're going to try to do it as quickly as possible. If they can get the treatment when they're ripe for it, they will. If they can't, they're going to go back out and use. And by the time that treatment slot comes open for them, there's a high risk that they're no longer going to be amenable to getting that treatment. And what we know about folks is that there's really not a whole lot of difference between the relapse rate with people with diabetes, with people with high blood pressure and heart disease, and the relapse rate with people with addiction. We need to be able to give them the same timely treatment that we give someone with a heart attack or with diabetic ketoacidosis.
Thank you. Doctor, we in the news business, which is my profession, we hear a lot about overdoses. It seems almost daily occurrence here in Laconia that the emergency responders are having to rush someone to the hospital for an overdose. Can you explain to the viewers out there today what actually happens to a person physically when they're overdosing on an opiate or heroin or fentanyl or something like that, a substance like that?
Sure. To keep it very simple, opiates stop you from breathing. They slow down your respiratory rate, and it just gets slower and slower and slower. I've seen people who are breathing 1 or 2 times per minute. And once you stop breathing, then you add in a cardiac arrest as well. So it's a very potent respiratory drug. And what we've seen with fentanyl is a totally synthetic opioid. In other words, it doesn't come from any plant. You don't need poppies, and you don't need poppy seeds, and you don't need processing. And because of that, and the chemicals are pretty readily available, unlike crystal meth, where you've got to have a supply of the pseudoephedrine, which is the generic name for Sudafed. These drugs here fentanyl can be made cheaply. We call it a bathtub drug because you can make it in your bathtub. And really, the overdoses started at spiking like this in the last 2 years when fentanyl arrived, because people can really increase their profits by adding more and more and more fentanyl. And drug dealers, they're not worried about the consequences of that potent narcotic causing people to die. So some of the overdoses we've seen here are 100% fentanyl now with no heroin. And the fentanyl, it acts a lot quicker. Some of Jackie and I's most seasoned drug abusers die with the needle in their arm. That's how quick it is.
Is fentanyl the same substance that Michael Jackson would killed him? Is it similar?
Michael Jackson died from propofol, which is really an anesthetic agent that you use in the OR to put people to sleep. But I'm sure fentanyl might have been in the mix somewhere. Fentanyl is really a drug that comes in patches that absorb over 24 to 36 hours, which are very good for end-stage cancer patients who can't drink or can't take a drug orally. And that's another example of a good drug out there that's been hijacked now. It's funny because I went and testified at the Senate in the fall, And a lot of the senators really didn't know, where was the fentanyl coming from. And I think a lot of people thought that people were just taking patches off dying cancer patients and somehow eluting it out. Well, you need a bathtub full of fentanyl. And so I think that the overdose problem, getting back to your question, is really you stop breathing. And the antidote, which is Narcan, naltrexone, the first day we gave it out recently, you were probably there. Some family members saved someone that day, and
So what Narcan does is it neutralizes the effects of the opiate and allows people to breathe again.
it blocks all of the receptors, so it's essentially an antidote, and exactly, you'll start breathing at a normal rate. What you have to remember is these one-dose type sprays or injections of Narcan, with so much fentanyl, you're going to need to do it 2 or 3 or 4 or 5 times. So the average person at home will gain a window of opportunity to get this person to the hospital. But the worst thing is to give it and then say, so-and-so's okay, because it's going to wear off.
Right.
It's going to.
And actually, when the people wake up, they're still addicted. They're still alive,
right.
but they're still addicted.
Right, and it's oftentimes after an overdose that folks will present to Jackie because it's enough of a scare to say, I want to do something.
But Jackie, thank you. With so many addicts out there today in our society, why is it so hard for people to seek help for addictions, and what type of treatments work best?
Okay. The second part's a complicated question. Probably both parts are complicated questions, but there are a lot of things that make it difficult for folks to seek treatment. The primary issue being that addiction is a disease of denial. We say that all the time, and we don't really understand what that means. But what it means is we all have a built-in system that says, I can do this, I don't need help, bad things aren't going to happen to me. And drugs make people feel good. So it's really hard to convince yourself when you're feeling good that the consequences that come afterward are going to are really connected to that good feeling. It's not till the addiction has progressed so far that you're chasing that good feeling and you never quite get there anymore, that life becomes so bad that you understand that you need to get help. The stigma attached to addiction is huge, and that gets back to the lack of understanding and the lack of compassion from our society as a whole of addicts and the disease with which they're struggling. Too many people today still think that it's not a disease, and that if it is a disease, it's a disease you gave yourself. That if you just don't use that just say no message from the 70s, if you just say no, it'll all go away. And the reality is, if you think about the fact how many addicts nearly die and don't get help because they just feel better by using again, the powerful draw that disease has on them. What kind of treatment works? It depends on the person. What everyone needs is a really good, solid assessment. Just like if someone comes into their doctor and says, I have a backache, you don't automatically do surgery. You diagnose, you figure out what level of treatment this person needs for that illness. We need to do the same thing for folks with addiction. Figure out where in the progression of the disease they are. Do they need outpatient treatment? Do they need intensive outpatient treatment? Do they need residential treatment? It depends. Sometimes it's a combination of all, and it's the ability to move back and forth between all of those treatments. And again, we need the adjunct of recovery supports for those folks.
Okay. Last question, Doctor. In your opinion, what are the community costs of addiction?
Well, It's interesting, Ed, because this is one of the hot topics as we look at ex- expanding and adding on a couple of years to the expanded Medicaid in New Hampshire. And I think that, what I've been talking to some legislators about is just in terms of money to a community, an active addict absorbs about $70,000 per year in healthcare costs, crime issues, the legal system. Someone who is in treatment, let's say a combination of medication like Suboxone, which is very inexpensive, Jackie's services, which also aren't outrageously expensive, probably costs an average individual 10 to 15,000 a year at the very most, and 95% of Suboxone patients are off it within a year. So we're not talking about ongoing, yet when these people stay active for 5, 6, 7, 8 years, the cost is ongoing, and that's just the cost. Underneath it is the nuisance factor, the quality of life for the community. Because if you ask the police, 90% of our break-ins, car break-ins, home break-ins, are addicts and impulse crimes. So, it's a low-level constant nuisance that affects everyone's quality of life. But then I get to the next layer because I've done this so long, and I see that every day, or like we said earlier, every 4 to 5 days, $1,000 have gone into a vein to ruin someone's health. That's a ton of money leaving the community to ruin health. And those people aren't going to spend that money on a car in the community or a restaurant or anything else. So the cost comes really to several $100,000 a year, not to mention the nuisance factors. And that's ongoing. And, it's hard to say how many active addicts we have in this area, but it's certainly in the hundreds. And when you look at treatment, it's not expensive. That's the amazing thing. I mean, myself and Dr. Friend put together the Suboxone treatment clinic in the fall, and we didn't need any equipment. We already had our own personnel. Right. We simply started seeing the patients.
Thank you very much. I'd like to thank both of our guests today for being with us. I'd like to thank Jackie Abakoff from Horizon Counseling Center and Dr. Paul Rassicut from Lakes Region General Hospital. And if you are the slightest bit interested in helping join the effort to eliminate drugs and substance misuse from the Laconia community, I encourage you to come to one of the Stand Up Laconia meetings, which are held on the fourth Thursday of every month at the Hewitt Center cafeteria. The meetings start at 5:30, and they are usually done by 7. And when you come to the meeting, we're going to put you right to work. It's a practical, and we're just a bunch of regular folks trying to make a positive difference in the community. And what it's really all about, Stand Up Laconia, in a nutshell, is making this community better and safer. Thank you very much.